All right, looks like our attendees are all in. I want to welcome everyone, or welcome back to the University of Michigan Concussion Center Speaker Series. Everyone on the call today is on the cutting edge of concussion research or care. So our goal of the series is to create a space where you can hear from and learn from some of the world's leading concussion researchers and clinicians. And we have an awesome speaker for you today. My name is Steve Broglio. I'm director of the Michigan Concussion Center. And just a few housekeeping items before I give a formal introduction to our speaker. Just as a reminder, we are recording the session today, and it will be available on our website, concussion.umich.edu, in a few days. Stan is going to give about a 45 or 50-minute presentation, and then following that presentation, we'll have some time for some questions and answers. But if you have any questions that come up along the way, feel free to put them into the Q&A function at the bottom. This session has also been approved for both CMEs and EBP credits, and we'll send an email out after the session with all the information you'll need to claim those credits. It is now my great pleasure to introduce Dr. Stan Herring. He's a clinical professor in the departments of rehab medicine, neurological surgery, and orthopedics and sports medicine at the University of Washington in Seattle. He is the co-medical director of the University of Washington Medicine Sports Concussion Program, senior medical advisor, and co-founder of the Sports Institute at University of Washington Medicine, and the Zackery Lystedt Sports Concussion Endowed Chair. In his spare time, he served as the team physician for the Seattle Seahawks, the Seattle Mariners, and is a consultant to the University of Washington Sports Medicine Program. He is also the founder of the American Medical Society for Sports Medicine, has nearly 100 peer-reviewed manuscripts, and was instrumental in getting the first concussion legislation passed in the United States, and his continued work to help pass similar legislation in 50 states and the District of Columbia. Please join me in welcoming Dr. Stan Herring for our speaker series today.
Thank you, Steve, and thank you for the kind introduction. It really is an honor to be here, and I'm excited to share some information with you. And I know I'm speaking to a very sophisticated audience, several of whom are more talented and knowledgeable than am I, and that is not an unfamiliar position for me, so I will proceed on. I would like to draw your attention to my title of the talk, and that is Youth Sports Concussion, Addressing the Athlete with Persisting Symptoms. And I would like to emphasize the word persisting and see if I can make the case with you for the next 45 minutes why I think that adding the word persisting to the lexicon of sports concussion is a very important and relevant addition. And that is work which I certainly have done with others, particularly calling out Donna Broshek and Jamie Party, who have worked on this with me and another group that we're working with. So it's certainly not my idea. Let me see if I can make my slides advance here. All right. My disclosures. I have been lucky enough to be in the concussion and sports expert panel group for several years now, and I will reference some of the Berlin work fairly extensively in this talk. I have been able to do some volunteer work with many, probably those called with the CDC, as well as the NCAA, and I helped design a new football helmet. I don't plan on talking about equipment in this lecture. I do plan on talking about Zach for a little bit. You mentioned Zackery Lystedt, and the Institute was formed in the honor of Zach, and here Zach unfortunately is at 13 years old after suffering a preventable brain injury while unfortunately allowed to be able to play. And through courage and fortitude, here is Zach at 27 with his parents, Victor and Mercedes. I like to start lectures like this by honoring the Lystedt family and their courage. And just to make it clear, there's no family that's a bigger fan of sports than the Lystedt family. They just want sports to be played safely, and a lot of our work is to try to honor that commitment for them. As I mentioned, the Berlin Consensus Statement, I know several people on this Zoom were there, and this will be mentioned. I'll use some language from the statement to try to build the case I'd like to build with you today. We know they're common, and everybody on this phone call knows that this is an extraordinarily common injury, sports-related concussion. It's also important to remember that the great majority, or at least half of them, are probably never even seen in a healthcare setting. And of those seen in a healthcare setting, most are seen as an outpatient. So this is, we need to be careful that we remember that a lot of these injuries never actually see medical care. And then we also know, all of us, that there's this rising reported rate of sports concussion. And certainly since 2008, I think the Lystedt laws themselves have resulted in more robust reporting. And so not surprisingly, and the more we know, the more we report. But the idea of a sports concussion crisis has made the news. There's a crisis around this injury. I'm not sure the injury is really any more common. I just think that there's a reporting bias now, which is a good thing. For those of us who were raised in the brain injury business, any attention to brain injury is good attention. But, in terms of crisis, there are dangerous things that we can do to children that will absolutely affect their long-term physical, psychological, and neurological health, as well as their academic performance. I mean, we can hurt them, and one way to guarantee to impact youth in this regard is to let them be physically inactive. Yes, we need to obviously pay attention to brain injury, and everybody on this phone call is committed to brain injury. And I want to make it clear right now that this entire talk is the whole idea that you must respect the brain injury. But at the same time, I think we have to be careful here. Concussion is not the only thing that can affect your health. As a matter of fact, I've gotten to the point now where I don't really give a concussion talk without talking about the flip side. Why is it important for kids to stay active? And the value is really quite extraordinary. Muscular health, motor skills, bone health, mood, cardiovascular fitness. It helps prevent inactivity-related diseases that occur in childhood. I mean, we are seeing an extraordinary number of children and young adults having type 2 diabetes, hypertension, asthma, atherosclerosis, fatty liver disease, much earlier than we've seen in the course of certainly my 4-decade career. And I think also it's critically to understand here that if you're active as a kid, you're active as an adult. And trying to get adults to be active to protect their health is really a challenge. And so if you're active and your kids are active, it's a good chance they'll be active when they get older. And there is clear evidence that physical activity prevents a variety of diseases, including at least is a very important prevention tool for 13 different types of cancer. The obesity epidemic, there really is an obesity crisis. Exercise alone doesn't do it, but along with diet, it's helpful to try to prevent obesity. And guess what? We have to protect athletes' brains from concussion, but exercise helps them have better brain structure and function. It improves mental performance and thinking. So we have to be careful here that we don't protect kids at the risk of making them inactive. Right now in the United States, children spend about 7 hours of their waking time in sedentary pursuits, most of that being screen time. About a quarter, only 25% of young kids meet the recommended dose of exercise a day, which is an hour to moderate to vigorous exercise. And less than half of American children have adequate cardiovascular fitness. So there is a problem with physical inactivity. And as we're talking about the obesity epidemic, the prevalence of obesity in children has doubled, and in adolescents has quadrupled over the last 30 years. So we have a problem, and physical inactivity is truly a problem. It directly and indirectly raises the risk of serious and chronic diseases across the entire lifespan. If you wonder why the United States does so poorly in its COVID responses, people who are obese and deconditioned who do worse with COVID, and we are certainly there. Physical inactivity as a standalone risk factor is felt to be the fourth leading cause for death worldwide. And you may wonder if I'm just an adult old man who's now lost focus of this concussion talk, and I don't think I have quite yet, but give me a chance here. What I'm really trying to make the point here, folks, is that we've really got to balance the risk of sports participation with the benefit of exercise. It's our duty not to divorce the two when we're talking about brain injury. One other thing I think we have to be careful about in terms of not inadvertently being prejudicial or judgmental is, I understand, we all do, that inactivity versus playing a contact or collision sport is not a binary decision. And in this work group, I was lucky enough to be part of this paper. We did a very systematic review, and the question was, will youth athletes change sports if you tell them to? Will they stay active? So we did detailed literature to see, the magic thing. Will they drop the football and pick up a golf club? There is absolutely no data, none. So we need to be careful about recommendations that may not respect the values of the athletes and their families, or the risks that they choose to take, where sometimes a contact or collision sport is the safest thing they can do, not the most dangerous. So I just want to kind of put that background into place, and I've sort of added that to all my concussion presentations. Speaking of concussion, Ray Sees, the remarkable Persian physician, the father of pediatrics, the first man to describe measles, wrote a textbook of medicine that was used for 1,000 years. And in that textbook, he described concussion. So the description of concussion is not new. Actually, it's an outstanding definition. He's not the only one. So for decades, eons, centuries, there's been discussion about concussion in the literature. So my question to the group is, the disease, the injury is not new. And my question to you is, what is new in the last 10 or 15 years? And we'll try to kind of go through that and see if we can make that case. All right, so going back to the Berlin definition, the one that has been used literally 100,000 times, we all know it. As it's defined, and as it's often quoted, we all know this is sort of traumatic brain injury, and has the different points to it that we've all read, and actually probably all used to define it in papers that you have written, or presentation you yourself have given about the direct blow to the face or head or body, and then the rapid onset of short-lived impairment that usually resolves spontaneously, with some cases where it does not. And while it may result in neuropathological changes, we still think of the acute clinical signs and symptoms sort of representing functional disturbance, kind of like running too slow of a software version. It takes you longer to do things. And then the wide range of symptoms, probably depending upon what part of the brain is involved, that usually do not in sports involve loss of consciousness. This was, since I was lucky enough to be part of the concussion in sport group, this definition stopped there until Berlin. And then this was added, that the clinical signs and symptoms cannot be explained by something else. And I am so happy to see this added, and advocated for it strongly when we were in Berlin myself. I think, once again, we all respect a brain injury, but part of respecting a brain injury is not attributing all signs and symptoms to something where there might be other etiologies. That does not help the patient. So this definition, I think, is a critical piece of this, and I'm going to try to discuss that a bit. So once again, in Berlin, I talked about this sort of large majority get better from a clinical perspective within the first month, and that there was a growing body of evidence. I mean, I know we're looking for biomarkers and genome and advanced imaging. We're looking for the magic biomarker, but in the meantime, there is a biomarker, and one of the biomarkers is that the psychosocial factors play a significant role in symptom recovery and contribute to persistent symptoms. We know this. So the strongest, once again from Berlin, the strongest and most consistent predictor of slow recovery is symptom burden. And a low symptom burden is helpful. And the development of subacute problems, for example, the athlete who gets concussed and then has a pre-existing or resulting migraine headache disorder, or they have pre-existing or coexisting depression, they don't get better as quickly. And children, adolescents, and even young adults with pre-injury history of mental health problems or migraine are at greater risk for having persisting symptoms. We all know this. We all know that, certainly everybody on this phone call knows this. The question is, can we act on it? We also know that ADHD kids recover differently. I'm not sure they recover more slowly, but they do recover differently. The other thing we know too, and this was in Berlin, I like this, is that there is evidence that during the teenage years, particularly high school, although high school isn't hard enough, this may be the most vulnerable time period for having persistent symptoms. And that risk is greater, at least reported to be greater in girls and boys. I don't know that there's necessarily any biological difference. I think that that's social and cultural. But that being said, so the case I'm making here is that we said in Berlin, and most people on this call know, that it's what the patient brings to the concussion that's often important in determining the recovery. So those adolescents with prolonged symptoms, once again, for kids, we're talking about kids now that have symptoms for more than a month. Based on, and I think this is right, I think 4 weeks is about right for the great majority of concussions in the absence of an athlete who's had multiple concussions or has had prolonged symptoms from previous recovery. For those other athletes, most athletes have symptomatic recovery within a month. But there are predictors for poor outcome, not just in the sports literature. And for those of you who take care of brain injury outside of the sports world, this is not new news, right? I mean, there's a lot of studies, and the studies that were prevalent when I was training, demonstrating that pre-existing psychological issues predict outcome in non-sports related pediatric concussions, and that child and family factors are strongly associated with persisting symptoms after concussion, and patients with premorbid conditions, including head injury, learning difficulties, not ADHD, everyone thinking behavioral problems, are an increased risk for prolonged recovery. So when you jump outside the sports concussion world and you talk to the brain injury world, they yawn when you tell them that you think there may be psychological factors involved, because this is a known fact. But a fact that I think we need to keep in the forefront when we look at children and adolescents with persisting symptoms after sports-related concussion. Is there any evidence in the sports medicine literature that supports this as well too? I bet Dr. Solomon is on the phone, because he never misses an opportunity to later call me and tell me what I did wrong. But it worked with Gary's group here in their retrospective case control study, which I think was very relevant here. They looked at 40 patients with persisting symptoms, and they collected some good data, as Dr. Solomon always does. And they looked at a lot of demographic variables, but they also had key medical, psychiatric, family history variables, acute and subacute symptoms. And who was at risk for developing persisting symptoms after concussion? If you had a history of previous concussion, yes, we know that. And delayed onset of symptoms, we know that kids who keep playing, everybody on this call knows that kids who keep playing seem to have more symptoms when attached symptoms that take longer to resolve. But also, again, Dr. Solomon and his colleagues show that those for risk for developing persisting symptoms were those who had a history of mood disorder, a history of significant life stressors, a family history of mood disorders and psychiatric illness, and a family history of migraine. Not just psychological issues, psychosocial issues were predictors of prolonged recovery. What did not predict prolonged recovery? Pretty much everything else. So all the things that we wonder about, all the things that are sort of easier to modify, if you will, really didn't predict outcome. So once again, when a concussed athlete comes in your office, what did they bring to the concussion? What life experiences, what personal mental health experiences, and what family dynamics did they bring to the injury? Also, the shop out of Wisconsin, McCrae shop, and his very talented colleagues, I like this study as well too. It's very well done. This was a longitudinal study of sports-related concussion. Big number, over 2,000 high school and collegiate athletes, and they were followed for up to 3 seasons, which is very cool. This is really nice work. Their preseason survey was big. It was an hour and a half, and their post-injury examination took an hour, and they were conducted 24 hours, 8, 15, and 45 days post-injury. And they measured a lot of good things. These are validated tools that were used for baseline and post-concussion assessment. And I will not make you read the whole list, but basically there's very good testing here for a variety of domains around both cognition and as well as balance, but also in terms of belief systems. And the research, of course, was perfect. It was very well done. And 127 of those 2,000 athletes were concussed and followed for up to 3 years. You know what was found here? What was telling, of course, was once again, it's very validated. The symptom burden is a very good predictor for recovery. That's why a good sideline assessment is so critical to get the burden of symptoms acutely. And in terms of what predicted how long recovery would take, the single best predictor was a pre-injury somatic symptom score, the brief survey, the brief inventory. So what their somatization scale, basically, if they were a somaticizer, that predicted recovery duration or symptom duration. Once again, powerful information and critical and incumbent upon us to respect that when we evaluate an athlete. So when we treat what people have called persistent, and I'm going to ask you once again to start thinking about calling it persisting. All right, so John Leddy. John is a courageous man. Back when we were cocooning patients, I never understood that. Our moderate to severe brain injury patients couldn't get on the rehab board unless they could exercise for 4 hours a day. But for some reason, we decided that we need to cocoon these concussed young athletes. And I think John and his colleagues said, I don't know if that makes sense or not. And they did early work that showed it wasn't dangerous to exercise people early. And then his more recent work is so extraordinarily helpful, where he did this multi-center prospective randomized clinical trial, good numbers, right age group for the conversation that we're having today. And what did John and his colleagues do? Their treatment group was his progressive subsymptom threshold aerobic exercise, which is once again now become part of the vernacular of concussion care. And then he had an active control group. And they had stretching, but they were all addressed the same. They both had 20 minutes of exercise. They both reported daily symptoms. It's just such a beautifully designed study. And John's outcome measures were the number of days to recovery. That was being asymptomatic. That wasn't return to play. It was when they became asymptomatic, or maybe it's better to say baseline symptomatic. And it was assessed by a physician blinded to the treatment groups. You know, and so treatment for both groups started around 5 days rather than waiting for a long time to exercise. And both groups had baseline treadmill tests. They had the same attention applied to them, just so very clever. And their exercise and stretching regimens were adjusted weekly, as you know, for the aerobic challenge. Once they can tolerate exercise, you retest them and set a new target rate, which is sub-symptom threshold. To make the study clear and clean, there were a lot of exclusion criteria. So they could not be on medication, have ADHD, couldn't have a learning disorder. They could not have signs or testing for depression, anxiety, or history of more than 3 concussions. For those who exercised, they got better faster than those who had the placebo-like stretching. So once again, Dr. Leddy and his colleagues have helped us by giving us permission to know that activation at the right time can be helpful for concussed athletes. Remember, again, recovery was defined as being asymptomatic with treadmill tolerance. This did not choose to look at where they were able to return to school or return to play. That still, the onus then remains upon you to make sure they're not just symptom-free with exercise, but they tolerate a graduated return to learn and return to play protocol. And because of the quality of the research, these athletes with these issues were not studied, which unfortunately makes it a bit more challenging to journalize this data, because at least in my practice, it's unusual for an adolescent athlete not to have one of these issues. It doesn't diminish from the study. I understand why the study was done. And just once again, you have to be careful how you generalize this. And you know, John's intention of all of his studies has been to measure symptoms, and I really appreciate that. But just so we're clear, it was not their intent to quantify the physical activity provided. He did not quantify the dose that was based on individual symptoms, because it's a pragmatic and very valuable study. But we do not know what dose of exercise is magic, if any, and what the exercise intervention actually meant in terms of changing cardiovascular fitness parameters. We assume that the exercise made athletes better because they exercised, and they had a change because they exercised. Just like we assume when you treat patients with low back pain that they get better because they do core stabilization exercises. Certainly in the back pain world, the patients get better before their cores even get stronger. And then Catherine Snyder, another brilliant concussion researcher and who's taken an increasingly large role in the concussion and sports group, and just a spectacular physiotherapist. I'm proud to call both her and John friends. Her trial, this extraordinary study, a prospective randomized controlled trial of concussed patients who had symptoms of some dizziness, neck pain, or headaches at 10 days. And they were 12 to 30, small N, but this was a very important sort of pilot study. And so what did she do? Well, for up to 2 months, both groups got their usual sort of education that they would do, but one group had cervical spine and vestibular rehabilitation, focused cervical spine and vestibular rehab. And she measured the number of days from treatment initiation till they returned to sport. And she measured some other secondary outcome measures as well, as listed here for you. What was not measured in this study was any formal vestibular function. That was not done with all these fancy equipment and that requires. So these scales, which are these tests, these measures, if you were, which are certainly part of the world of manual physical therapy and vestibular physical therapy, were used as well as just this return to play. So it's amazing what she found out. So the primary treatment group were medically clear within 8 weeks, and the control group only 7%. So 73% versus 7%. So by doing her intervention, for those who had dizziness, headache, or some sense of persisting symptoms, and that could be oculomotor or vestibular, you cannot argue with the outcome. It was dramatic. Secondary outcomes, those other measurables. The only two things that really changed in the treatment group were their SCAT2 scores were better, but we sort of know now that this is really not designed as a tracking tool. And it has some objective, but some subjective component. And then the dizziness handicap inventory score. And I am sure on this call there are physical therapists who know this world, and please excuse me for just maybe not getting this perfectly right. But my understanding of this test is it has 3 components: a physical, functional, and emotional component. So there is an emotional reporting component to this index, and it does require patient input. So it requires patient reporting to you how they feel in terms of their symptoms, and there's 3 subscales. Gina McCarty is at the University of Washington Children's Hospital, and this is a study that I know well. When they pilot study for this done, I was one of the collaborators, so I will disclose that. So what did Dr. McCarty and her colleagues do? They went a different route. They took 200 kids, and from a pediatric primary care practice in the rehabilitation and neurology practice in Western Washington, and they just took kids who had symptoms in a month, and they had 3 symptoms lasting at least a month, and they had a concussion for the last 9 months. No assessment, no vestibular ocular motor assessment beyond the normal was done. They weren't randomized that way. They were just simply randomized. If they had symptoms for a month, half of them got collaborative care and half of them got usual care. And collaborative care means a care coordinator, cognitive behavioral therapy, mostly through telehealth, and when warranted, medication consultation with psychiatry. That was the intervention. And then the comparator group had usual care. She also measured a lot of things using validated outcome tools. She measured post-concussive symptoms with a validated outcome tool, health-related quality of life, depression, anxiety. Once again, for those neuropsychologists and psychologists on the phone, these are all the tools that you use that make us all smarter. And then they also did some social measurements, satisfaction with care. They looked at sleep, they looked at headache, and they looked at suicidal ideation. So once again, nice study, validated outcome tools, follow up to a year. So what happened? Adolescents who received the collaborative care model improved. Their post-concussive symptoms improved compared to those who received usual care at 3 months and 12 months. They did get better. Adolescents who received collaborative care reported improvements in health-related quality of life compared to usual care. So they, once again, this intervention, this collaborative care intervention, which was basically cognitive behavioral therapy and medication when needed, as well as just having someone coordinate their care, really made their quality of life better. It made their symptoms less, their sleep improved. And perhaps for those of you who are in clinical practice, the most important outcome in my mind was not only that they were happier, their parents were happier. As we all know that if an adolescent gets a concussion, there are 3 people who are suffering at least when they come in the room. So this I found this fascinating that they felt better and their families felt better. They felt better, I think, probably because they saw their children suffering less, and they were given a plan that offered some hope for those patients. There were no group differences across time for headache. And interestingly, there were no group differences over time for depression or anxiety symptoms, which I thought was not explainable. It certainly hurt my belief system until I read the paper in more detail. 40% of the control group during this time received mental health care. I think this is a real world study with adolescents enrolled from multiple practices, just so you know what's coming in to see you when they have a concussion. Once again, remember, it's what the patient brings to the conversation. Well, 40% of those patients in the control group had baseline depression or anxiety. So maybe not seeing a difference in outcome was because the groups were not different. This makes my point perhaps even stronger. So during that 12-month study, 3 athletes in the collaborative care group and 4 in the usual care group required psychiatric hospitalization or residential care. And 3 in the collaborative group and 2 in the usual group had a suicide attempt. I obviously have some bias for the study because it was done with colleagues that I know in our institution, but I think that this is an important conversation. I'm going to say it again, and maybe at the risk of being redundant, this in no way suggests that these kids weren't concussed. This in no way suggests that you do not have to respect and thoroughly assess the head injury. I don't want that to be the perception here at all, but it does suggest that those adolescents with persisting symptoms have a complicated story. So the mystery is in the history. I think that's what at least I've learned from watching all this research kind of come to pass. So what am I trying to say here? Let's look at this. So Dr. Lystedt uses submaximal exercise. He doesn't really report that the patients had vestibular, cerebrospinal, oculomotor rehab per se, and he doesn't report any addressing the mental health. He has success. Dr. Schneider, for those who have some vestibular symptoms, focuses on that treatment, not the other two, and she has roaring success. And then Dr. McCarty doesn't even ask about exercise or vestibular. Maybe they get it, maybe they don't, but she focuses the persisting symptom patients on mental health treatment, and they got better as well. So this is kind of interesting to me. So I guess in modern day world, everybody got a trophy, right? Everybody won here, which really raises the question we have to ask, what are we treating? So are we treating brain injury, or as Dr. Koppel, my neuropsychology colleague, says, you treat the brain, I treat the mind, as he likes to point out. What are we doing here? Everybody got better with these interventions, all of which have value. So it does raise a question. And I like this graph just for fun. You know, we all know the difference between association and causation. Yes, global temperature is rising, and yes, the number of pirates are rising in the world too. I'm not sure there's a cause effect there, but there's an associated effect, right? So if the temperature is higher and there's more pirates, we probably shouldn't assume that global warming has caused more people to become pirates. Another way to think about this is as follows. This is the American Medical Society for Sports Medicine consensus paper on, updated paper on concussion in sport, and I was one of the authors. And I watched with great interest as we designed this infographic. And the conversation was around subtyping. And maybe there's cognitive concussions, and maybe there's fatigue concussions, and maybe there's migraine or ocular concussions. And we would talk about it. And the more we talk about it, I say, well, there's a lot of overlapping symptoms among all of these. And I am a believer that there's a reciprocal relationship between the number of words on the slide and what we actually know about something. There's a lot of words here. There's a lot of words here because no matter how hard we try to subtype concussion, try to make them fit a medical model, try to medicalize them. If you look at all of these symptoms, many of which are psychosocial, I don't think you can divorce. I don't think Western linear medicine works here. I don't think you can divorce the overlap that affects all of these domains. Yes, if someone has a migraine headache, you should treat it, but you also need to know who they are. And maybe their migraine is being driven by persisting problems after a concussion, and maybe it's being driven by a lot of other factors. So the burden for us is to know who we're treating. I realize that may sound obvious, but maybe the simplest lessons are the most important, particularly when it comes to the concussion space, because we all know how much attention concussions have commanded in the public eye. So while I applaud in the effort to try to subtype these, I think we're a long way from divorcing the commonality of many patients with persisting symptoms, which is who they are, what their life experiences are, what their belief systems are. And speaking of patient beliefs, in my other life, I had the privilege of taking care of patients with complex musculoskeletal injury and pain. And in the pain world, and once again, I'm going to apologize to the psychologist on this phone call if you've still stayed on this Zoom for my ham-handed effect to explain this. So I'm not trying to be a psychologist here, but I learned in the pain world that there definitely was a Hawthorne effect. That sometimes no matter what we did for patients with pain, if we paid attention to them, they got better. If we just did something to them, if we just talked to them, if we gave them anything, they got better. I also realized that if you gave patients back locus of control, if they would do better. So I used to say to my residents this, I don't know if it's core control for back pain. I think it's locus of control. I think you're giving them permission to do something and saying, this is in your control and this will make you better. Because as I said earlier, it's amazing to me how patients with spine problems can do core exercises. They get better, but we really haven't even done enough exercise challenge to increase the strength, endurance, power, or motor control of their core. But they still get better. Doesn't mean we don't need to do those things. It's just interesting to me why they report getting better. And then the third model I want to discuss here, which I think may have some relevance for this group, is a fear avoidance model. Exposure therapy works for chronic pain. I wonder if it works for persisting symptoms after concussion. If just desensitizing someone to the fear, the learned behavior around some of their symptoms helps them. I'm going to say it again. It does. You don't do this at the exclusion of making sure that you haven't diagnosed a brain injury correctly. Just saying, for those with persisting symptoms, it's never easy and it's rarely one thing. There is supporting literature. I didn't want Dr. Broglie to think I had completely gone off the ranch here and not giving him some science. There is supporting literature now, which is looking at the pain, the tools we use in pain, and applying them to concussion. I think there's fertile ground here. And once again, this other group, this wonderful group that I'm working with now, we're kind of exploring the idea of kind of maybe measuring some of these outcome measures in an office setting to see if they might be relevant. And I think probably we will find out that they are. I will tell you as an aside, the Department of Rehabilitation Medicine, University of Washington, has opened a post-COVID recovery and rehabilitation clinic, and it is impossible to distinguish those patients from those patients with persisting symptoms after concussion. The story, the presentation, the concerns are so remarkably similar. I think we need to be careful. And why I say that is, once again, I think all of us as healthcare providers, I know that I am sort of biased by motivated reasoning. I like to interpret things from my point of view. I like to make data fit my belief system, and so yes, if I'm a believer in exercise and I exercise my patients and they get better, I say, well, exercise fixed you. And that probably is not damaging, but probably not necessarily scientific and not necessarily true. And the other thing I think is worth mentioning here, if you don't know brain injury, I mean the whole spectrum of brain injury, then you may not recognize when the pattern you're seeing is not brain injury. And particularly for complicated and persisting symptoms, I don't think this is a place for dilettantes. I think that you need, like anything else in medicine, If it's really complicated and it doesn't fit a pattern and it doesn't get well in a particular time frame, probably need to understand why it is, or ask people who do that work all the time, is this still just brain injury, or has something else entered the fray as well too? And I think this is, I'm so happy once again that the brain injury getting the attention that it hadn't had for forever. But I think we got to be careful here to be fair to patients with brain injury and to be fair to patients who can get better. We need to make sure that what we're calling concussion and the words that we use and the treatments that we offer are really oriented to the problem, and we're not missing something else, which persistent symptoms in Berlin does not reflect a single pathophysiological entity. And that's almost always true. It's a constellation of non-specific post-traumatic symptoms that may be linked to coexisting or confounding factors, and they don't necessarily reflect an ongoing physiologic injury. This is in the Berlin document. Once again, I was so happy. I think I read it on the airplane on the way home so many times because I was so happy to see it in there. And you got to look. So when you have these patients, you have to look, and that evaluation needs to be multimodal. And you need to identify specific primary and secondary pathologies. If they still have a brain injury, you got to find it. If they're still suffering, if you've missed a intracerebral contusion or a small subdural, you got to find it. And you also have to look for secondary issues that make symptoms persist. So at the minimum, your assessment, comprehensive history, focused physical and special tests, like Dr. Letty's graded exercise test, to see how they respond to that. As far as treatment, it has to be individualized. If you've seen one concussion, you've seen one concussion. It has to be individualized and target specific. And particularly for persisting ones, it has to address medical, physical, and psychosocial factors. And there is preliminary evidence, as we talked about. Yes, there's evidence that patients with persisting symptoms respond to submaximal exercise treatment, and we do it. I would encourage it. They do respond to targeted physical therapy, and this is not months of physical therapy. This is 4, 6, 8 sessions of physical therapy. They do respond, and they clearly respond to collaborative approach, at least in my belief system, my motivated reasoning. So what I'm saying here, and I'm not the only one to say it, not the first one to say it, nor am I the person to say it the most eloquently, but what I'm saying for persisting symptoms after concussion, you know what we need to do for our patients? We need to offer them hope. This is a treatable problem for the great part. You have to be very, very careful as a healthcare provider to give a diagnosis for which there is no cure. That's a very daunting thing to do to a patient. So when I ask what's the difference between 1,000 years ago when Dr. Racy's described concussion and we are talking about concussion now, it's the disability associated with it. And that is concerning. This injury has become remarkably and sometimes unbelievably disabling. Once again, sometimes it is. But we have to be careful here. We have medicalized this to a point where we are, and I couldn't agree with the dog more there. I think the dog agrees with me there. All right, so let me just stop here and take questions and cover things I didn't say correctly or didn't cover at all. Let me close with a few things. First of all, these are difficult cases and they need to be managed in a multidisciplinary collaborative setting. We don't manage these by ourselves. We have a whole program that manages these. Dr. Broshek and Dr. Part and Jamie Party, Dr. Party, in 2019, we kind of brought this forth in a Congress for Athletic Brain Health. And Donna, in her brilliance, said, so what's wrong with using the word post-concussion syndrome? Well, syndrome is a group of signs and symptoms that occur together and characterize a particular abnormality. I don't think persisting symptoms is necessarily a particular abnormality or condition. And I don't think that it indicates a specific condition, even if there's a direct cause not known. I don't think that most patients with persisting symptoms after concussion fit this diagnosis. Matter of fact, we don't use this diagnosis except in very specific situations. What about persistent versus persistent? Well, persistent means that this exists for a long time. It's inclined to persist. It continues to exist. It implies unremitting, unrelenting, whereas persisting continues to exist past the usual time frame or normal time, but it does not imply it's unremitting or unrelenting. So what does the word persisting do? It offers hope. And I think that that is important in this context. Once again, not to disrespect any brain injury, but I, like all of you, I have so many patients who come to my office who they're resigned. I've hurt my brain is damaged, and it will never get better. And that is a challenging thing when it's an adolescent. So I was lucky enough to be part of a group that just published in the British Journal of Sports Medicine. We published a team physician consensus statement. We updated our concussion statement. And so for the first time, we've introduced a term, persisting symptoms after sports-related concussion. And let me share with you what we said. The majority of athletes recover, as we've said earlier, and it's 2 weeks for adults and up to 4 weeks for children. But persisting symptoms is defined as symptoms that last longer than a typical time frame. The pathology is not entirely understood. It is thought that persisting symptoms after sports-related concussion are not caused by a single pathologic process, but rather an interaction of post-injury symptoms that are complicated by pre-existing, coexisting, and resulting biopsychosocial factors. It is important to perform a thorough evaluation for other etiologies of symptoms such that these may be identified and treated appropriately. What factors are associated with persisting symptoms after sports-related concussion? Well, high symptom load, as we've said, without question. Prolonged bed rest, mistreating the concussion, unrecognized or untreated or inadequately treated. It remains your duty to make sure you are not missing something. And then getting hit again when you're still symptomatic, we understand that that certainly prolongs symptoms. A personal or family history of migraine or mood disorder, and a pre-morbid diagnosis of learning difficulties, family and psychosocial stressors. The biggest predictor for persisting symptoms are pre-existing mood disorder and high symptom load. I think it's important for us to remember this as we approach these athletes. So, respect the brain injury. Always respect brain injury. However, if we overlook or misinterpret pre-existing, coexisting, or persisting medical, musculoskeletal, or psychological symptoms, we can make the treatment expensive. We can make it prolonged. We can unnecessarily restrict from academic, sporting, and social activities, and we certainly skew the data on sports concussion. And Dr. Brogley, I would like to thank you in front of everyone for the incredible work that you're acting one of the co-leaders. The NCAA DOD data is going to help us in this space. And we all owe you a thanks. We need that type of true data so we can understand how these symptoms recover in young people. So I've thanked you before. I'm going to thank you again. All right. So the pieces of the puzzle, I think this idea of understanding who we're treating and what they bring the injury certainly has defined my practice. And I hope that I've made the case that it's a conversation worth having. I will stop by giving you a view of the beautiful Pacific Northwest and thanking you for this really privilege to speak to this austere group. And I will stop talking, Dr. Bovdale.
All right. Well, thank you, Stan. I appreciate you sharing your knowledge today and your kind words at the end, of course. We have a very large team that does all the heavy lifting on our end. So we extend our gratitude to them as well. So just as a reminder, everybody on the call today, we're going to be taking questions through the Q&A. We have a few of them lined up already. So we'll get started with those as other people are forming their thoughts. So Stan, this first one here, how does one distinguish between classic migraine precipitated by a trauma versus a headache with migraine caused by the pathophysiology of MTBI or concussion?
That's a great question, which means the question is going to be better than my answer. So here's my short answer. Interestingly, cervicogenic headache after migraine is actually fairly rare. The headache specialists with whom we consult say that many persisting post-traumatic headaches have a migrainous component to them. So I think the first thing is to make that assumption. You can do some empiric trialing. Sometimes you see if they respond to indocin. But, you have to understand, once again, migraine headache, unilateral, the symptoms that are associated with it versus the symptoms that are not. But the short answer to your question is a migraine family history is important. The characteristics of the headache are important. And headache persisting in the absence of other symptoms, it's not, you don't have persisting symptoms when you only have one, and that's a headache disorder. And I would encourage you, the short answer, if the only remaining symptom is headache, it's unilateral, sometimes it's precipitated by effort, I would strongly encourage you to think migraine or migraine-like headache and seek assistance to manage that headache. So many kids are kept out of play because they think the persisting headache is a manifestation of the brain injury when it turns out to be a headache disorder.
Great. This is an interesting one. Is your group, or maybe of another group, working on studies that compare different treatment approaches? So vestibular rehab versus exercise versus cognitive behavioral therapy, either head-to-head. We've done this with all sorts of neuropsychological testing, balance testing. So either head-to-head or maybe various combinations of these approaches.
It's, Steve, I think you and I have even dreamt about this. One of the studies would be wonderful to be done, would have patients randomized to these three treatments, regardless of their presenting symptoms, and just see if there's any difference in their outcome. We've talked about it. I maybe can convince the group of children to do so, but I do think that's important. Or conversely, we should measure things from our treatments that we think are making people better. One thing about Dr. McCarty's study, those are validated outcome tools, right? So if we're going to have an exercise intervention, we should probably measure fitness parameters. And if we're going to have a vestibular and oculomotor intervention, we should probably go to the effort. It's so painful and expensive to actually measure objective oculomotor changes to see if what we're doing is doing what we think we're doing. It doesn't diminish from doing it. I don't think there's any harm here. It's just that I caution people being careful, believing that what they're doing is doing what it's doing because they think it's having the effect they think it's having. It's more complicated.
All right. So here's one maybe more on a practical level. Do you use either the PHQ-9 or the GAD during your evaluation of a concussed athlete, or maybe there's another form if it's not those? And if yes, how often do you administer?
Right. That's a very important question. The answer to your question, the answer is yes, if symptoms linger. If someone's going to be better in 5 to 7 days, not necessarily, but the minute that things get stuck, the answer is yes. But I have the luxury of, I have the GAD is a tool that my colleague, Dr. Popple, a neuropsychologist, can use. So when we see things going off the rails, we bring the team in. It may be as quickly as 2 or 3 days. And so I do think, Stephen, I hope that for all of us on this call who are going to be in Amsterdam in 2022, that we can talk about adding scales like an anxiety, depression scale, and maybe a catastrophication scale to the office version of the SCAT, because I think they have to be measured.
That's a great suggestion, Stan. We'll try to get it done. All right, we're going to move, to change gears just a touch. We're going to move away from return to play. We're going to go into return to learn. Can you describe some of the recommendations you and your medical team provide academic stakeholders who are working with pediatric patients suffering from persisting symptoms after concussion? What are some of the specific challenges academic stakeholders need to be aware of when assisting these patients?
Yeah, thank you for that question. The biggest problem you have to be aware of are doctors who think they know your job. That's your first problem. We need to let educators help us decide how kids should get educated. So I'm a fan of working with people who know how to educate children. I think it's very important. A couple of things. Kids should not have final recurrence for return to play until they've returned to learn at their baseline. I do think baseline is important, though. It's not that children don't have any symptoms. It's not that they are A students. It's who they were before they were concussed. And I think the educators are critical there. I also think it's really important that we don't just uniformly say you can't go to school. I think we have to be as aggressive about return to learn as John Letty is about exercise. And you don't damage kids' brains further if you press them a little bit. If they get symptoms, you drop back on your recovery. So short answer, work with the educator. I do think that it's helpful to have a team in place before the concussion. I think if the team can communicate together, that's critical. I think that limiting exposure you can sort of like submaximal exercise. I think working after you get symptoms is helpful. It's been my experience as a non-educator that one of the more frustrating things for students, particularly those who are as motivated as a student as they are an athlete, is they get behind and they get anxious. So some plan to mitigate the workload, some plan to postpone testing, but I hope that we don't get into this issue of uniformly getting kids 2 or 3 months behind or out of school for a long time. I don't think the great majority need to be there. So for the academician, the educator asked this question, if you can get to the sports medicine team and make sure that you're an essential part of that return policy so that you work together and they'll trust you to understand the academics, I think it's better for the kids.
Right. All right, just a couple more here, and we're going to be at the top of the hour. What can we do to address disinformation around concussion? That's an easy one for you.
Yeah, that's an easy one. Listen, what a great question. It sounds like that whoever asked that question, Steve, has been in many of a bar with you and I as we discussed the same thing. I've never seen a topic that has so much information that is probably not accurate. I mean, I usually start my visit by saying, what did Dr. Google tell you? And then I don't talk for a while. I say, you tell me in your own words what you think is going on with your brain. It's fascinating. And so we often call our first visit the unlearning visit, because it's not what you know. It's what your patient and their family know and what they believe. And until you get past that, they cannot hear one word you say. I hope, once again, Steve, that the work that is coming out of NCAA DOD provides data. I hope that the leaders on these type of Zooms take this message and promulgate it. But I have a concern because this social media is a very powerful thing. And I am beginning to wonder if, Steve, concussion programs like yours and ours need to spend more time in that space, saying, phrases that are helpful. There's hope here. This is treatable. Don't give up. And this group that I'm working with, and I'm so proud to be part of, we're trying some things in that space too. I think it's really important that we address this on the social media side. I think we're losing the conversation. And I also think, listen, this is not a Freudian issue. Either if you don't believe that all concussions are disastrous, that doesn't mean you're in denial. It's not Freudian. There is nuance here. No one on this call wants to hurt a kid. No one. I mean, for goodness sakes, we honor the Lystedts every day. But at the same time, there has to be a place for dialogue around this conversation so we can all get smarter.
Thank you. That's a great way to end it, Stan. Excellent messaging. I couldn't agree more. So thank you to everybody who joined us today. I'm expressing that on behalf of the Michigan Concussion Center faculty and staff. And Stan, of course, we appreciate your time. I know I learned a lot today. We've known each other for a number of years, and you continually fill my brain with new information. So appreciate that. As a reminder, we will post this talk on our website in the next day or two, concussion.umich.edu. And feel free to follow us on Twitter @UMichConcussion. And as I mentioned at the top of the hour, for those seeking CME and EBP credits, we will email you after the session with all the information that you'll need to claim those credits. And our next speaker will be on October the 28th, John Leddy from the University of Buffalo, who will be talking about concussion physiology informs treatment. He will be on campus, so we're very excited about that, and we will do our best to live stream that out as we have done in the past. But until that time, thank you very much. Thank you again, Stan, and I hope everyone stays well and stays safe. Thank you.